And this is the lateral view. This looks a bit complex. Sagittal view. These are the vocal cords, epiglottic, epiglottic folds, and this is the subglottic area. So larynx has been divided into three halves, as the slide suggests. The part of the larynx which are above the vocal cord, that is glottis, is called supraglottic region, and the part below the glottic called, as the name suggests, subglottic region. This classification is important, especially when we are dealing with the tumor of the larynx and staging the tumor. So remember this classification, classification. Uh, Vocal, if you look at the supraglottic, so it involves the epiglottis, an epiglottic fold, erythroid cartilage, false cord, and the space between the true vocal cord and false cord called ventricle. These are all part of the supraglottic. Glottic is just a vocal cord that takes perfect emission, and subglottic is the undersurface of the vocal cord up to the 5 millimeter. Below that is the treaty. All right. This is another picture. Let's move to the other picture of the same. Right. This is the front view, and clearly this is posteriorly, and this is the lateral view. Again, you can see on this lateral view, epiglottic and epiglottic fold. This is the thyroid cartilage, to which the false vocal cord and true vocal cords are there. This is the space for ventricle, cricoid cartilage, and below the vocal cord up to 5 millimeter is the, up till here is the subglottic. So cricoid is a part of the subglottic region. Okay. Again, this is showing a closer view as epiglottic fold, epiglottis, false cord, true cord, ventricle, and subglottic region. So if you look at the larynx through the mirror indirect laryngoscopy or with the direct laryngoscopy, so anterior, this is anterior, this is posterior. So this is if you're looking with the indirect laryngoscopy with the mirror, so you are sitting in front of the opposite the patient. So this becomes the right side and this becomes the left side. Okay. So vocal cords, epiglottic fold, erythroid cartilage, false cord, epiglottis, and this is the piriform fossa, and this is the post-vocal area. Okay. So hypopharynx is divided into three parts, which is the piriform fossa, which is this area, and then is the post-cricoid area, just behind the cricoid and the posterior wall of the hypopharynx. This is the view which we see through the fiber optic laryngoscope. So it is upside down, and this is anterior, this is posterior. These are the piriform fossa, erythroid cartilage, epiglottic fold, false cord, true cord, epiglottis. Okay, so tumor of the larynx and hypopharynx. What is the commonest tumor of the malignant? We are basically concerned, focus on the malignant tumor of the larynx. So which is the commonest malignant tumor of the larynx and hypopharynx? Anybody? Nobody knows which is the commonest malignant tumor of the larynx? No reply. 99 लोग बैठे हुए हैं. Any wild guess? Okay, is it squamous cell carcinoma or adenocarcinoma? It is like, what is the normal lining of the larynx? Normal anatomy, histology.
Squamous cell carcinoma.
Good, at least somebody spoke. Okay, Sanjana, your name is appearing on the screen. Okay, that's very good. The commonest is the squamous cell carcinoma. As I said, we'll focus on the malignant tumor, not on the benign tumor. And then it's the adenocarcinoma because of the mucus gland and the salivary gland, minor salivary gland. Sarcoma and others are there, and again lymphoma is also there. But this is the commonest carcinoma. So what is the predisposing factors for the squamous cell carcinoma of larynx and hypopharynx? जल्दी से बताया करें. तो बहुत इजी है, सबको पता है कैंसर किस चीज से होता है. सड़क से किसी आदमी को खड़ा करके पूछो, वो बता देगा.
Smoking.
Good. Smoking is one of the causes. And after में लोग क्या खाते रहते हैं सड़कों पर? Sorry, क्या खाते रहते
Tobacco
हैं?
use.
Tobacco use. Yeah. Okay. So Charlie pan smoking. I think smoking, as this picture shows. You can screen so that I can see this. So as this screen is showing you, tobacco and alcohol is the commonest cause of. I don't want to see my own picture, but tobacco and alcohol is the commonest causes of the laryngeal carcinoma and hypopharynx. Human papilloma virus, as I suggested, in the oral cavity and oropharynx tumor. In oropharynx and hypopharynx, HPV is one of the causes, especially in the West, not in Pakistan, fortunately. And most of the tumor of the hypopharynx and oropharynx are due to not tobacco and alcohol, and also due to HPV virus. Okay, these are the general factors: diet, rich in salt, preserved meats, but do not forget tobacco, alcohol, and human papillomavirus. All right. Some of the occupations are important. Some of the people who are exposed to paints, especially or asbestos or gasoline fumes or plastic or metallic workers, may be due to they cause malignancy in this area. Exposure to radiation. Residual failure reflex is written in the literature, but I'm not sure how common it is. The residual failure reflex is itself is common, but whether it leads to laryngeal cancer or not, I think less than 5% patients who presented to have no history of tobacco and alcohol. So we may have to think of these minor predisposing factors or hereditary factors. Okay, so as I said, we divide into three parts when a patient comes with when we're suspecting tumor of the larynx. So we would like to know which part of the larynx it is arising from. Okay, so how does the laryngeal carcinoma or laryngeal tumor would present clinically? What symptoms they would have? Anybody?
Hoarseness.
Good. That is one symptom. शाबाश. और दूसरा कोई और बताएं? Second symptom.
Dysphagia.
Dysphagia. Excellent. Or okay. So, yes. Go ahead. बोले बोले. घबराएं नहीं.
सर डिस्निया हो सकता है किसी किसी केसेस में?
Dyspnea बिल्कुल हो सकता है. In advanced cases, we'll talk about it. That is straddle. That is why I gave you the straddle lecture last week. But this is difficulty in breathing हो सकती है. Hoarseness, dysphagia. Okay, so this is a hypophageal carcinoma which we will talk about. These are the three areas. So hoarseness, dysphagia, stridor, as somebody said, dyspnea, and lump in the throat. Now we see a lot of people coming to us in every clinic. 20-30% patient comes with, especially female, that there's feeling of lump in the throat, and majority of them, more than 90%, have got no tumors. But we always examine the larynx with the mirror of the fiber-optic laryngoscope to rule out malignancy tumor. Less than 10% or 5% may have a early stage tumor, especially of the hypopharynx, that is piriform fossa, which can in the very beginning present with a lump in the throat with very subtle symptoms. Occasionally, patient may not have all these symptoms, but patient may come with a neck nose. And this we call occult primary. Occult means, as you know, hidden primary. So patient may have got the metastatic node in the neck, but if you examine the upper aerodigestive tract, you may not find any tumor. And the treatment of occult node is different. We will discuss this in the management of neck masses. Okay, so supraglottic carcinoma का सबसे पहला symptoms क्या हो सकता है? What could be the earliest symptom in supraglottic carcinoma? It could be an MCQ. अगर आज MCQ में a hoarseness, lump in the throat, odylophagia, dysphagia, the earliest symptom or shadow it will be lump in the throat. It's the very big early stage, and patient may not come to us. Patient may ignore it. A lot of us sometimes get the feeling of lump in the throat and we ignore it. Unfortunately, as I have said several times, patient comes to us quite late, and but this is the earliest symptom. The top, there is a high incidence of neck node metastasis, almost up to 60% in supraglottic carcinoma, because there is rich supply of lymphatics. Okay, so lump in the throat, odynophagia, that is painful swallowing, dysphagia, and if it goes and involves the vocal cord, or if it involves the recurrent laryngeal nerve causing paralysis or fixation of vocal cord, then they will present with hoarseness. There may be cough. Lot of people comes with it. Just one symptom, irritating cough. Again, we'll look in the larynx just to rule out any a sinister cause. Stridor, if it is involved with the vocal glottic area, and it is a large tumor, or involved in the supraglottic area, it is just covering the vocal cord area. It may not be involved in the vocal cord, but it's a big lump over the epiglottis, hanging over the glottic region, then the patient will have difficulty in breathing with this stridor. Neck node. Okay. On examination of the larynx, we will see ulcerative or fungating growth. Now, uh, glottic carcinoma. Previous slide was showing supraglottic carcinoma about 40% present with, but glottic carcinoma more than 60 to 70% of the carcinoma arise from the vocal cord because of the smoking. The smoke goes there and causes changes, dysplasia, metaplasia, dysplasia, and then malignant changes. Neck node metastasis, unlike supraglottic, is very rare. It's about less than 5%. In supraglottic, it was almost 60%. Earlier symptom is it is obvious how hoarseness, cough, stridor, and in the late stages, the patient will also have dysphagia. And again, on examination, there will be growth, ulcer or forgetting growth, or in the very early stage, there may be thickening or a small ulcer. But in the advanced stage, there will be large forgetting growth. And subglottic carcinoma per se present very rarely. By the time it is involved subglottic, it has already involved the vocal cord or supraglottic area. But primarily tumor arising from the subglottic area. What will be the first symptom if the tumor is only arising from the subglottic area, that is below the vocal cord? What do you think will be the first symptom? Would it be hoarseness, dysphagia, or difficulty in breathing? That is stridor.
Difficulty in breathing.
Good, great, excellent. The stridor will be the first symptom in very early stage of subglottic carcinoma. But remember, if a patient comes with stridor and hoarseness, don't think it is subglottic carcinoma. Most of the time, it has already involved all part of the larynx. Okay, but very, very rarely, patient will have some very mild stridor in the small tumor arising from the subglottic. The subglottic carcinoma per se is very rare. It's usually a extension from the glottic or supraglottic carcinoma. Okay, so transglottic carcinoma is when it's involved all the three parts, and most of the patients when they come to us, if they come late, and by the time they present to us, it has involved all the three parts of the larynx. So these are the symptoms. I'm just repeating my slides so that you can get these ideas. You do not forget. Okay. So hypopharynx again, as I said, piriform fossa, post-precord region or postophageal wall. The first symptom will be like supraglottic lump in the throat or odynophagia. Okay. Now sometimes the patient comes with otalgia, which we call referotalgia. And if you examine the ear, doctors are giving them unnecessary topical ear drops and antibiotic, but if you examine the ear would be absolutely normal. So we call it referotalgia. The causes could be very mild causes like some dental problem or some dental abscess can present, or dental caries can present like referotalgia, or some sinister causes like tumor in the oropharynx and hypopharynx. So whenever patient comes with otalgia, and if the ear canal is normal, the next question will be if they have got any other symptom like toothache or lump in the throat or odynophagia or dysphagia. Okay. So history, obviously, we ask all these questions. We are not going to in detail about how to take the history here. It will be done in your clinical postings. So it's important to ask their addiction history, and also in the history, like any other disease, general health of the patient, general medical history is very important. Occupation is also important. Sometimes, as I said, people who are exposed to some chemicals like paints or fumes or asbestos, these things can cause laryngeal carcinoma or bronchial carcinoma. Okay, so early symptoms will be in glottic carcinoma. Is again repeating myself, hoarseness in the supraglottic and hypoglottic. It will be dysphagia and lump in the throat and subglottic strata. Remember early symptoms. Later stages, all above symptoms. Okay. Now, obviously, we examine the larynx with indirect laryngoscopy or fiber optic laryngoscope, and you always do the general examination to see the nutritional status of the patient. If patient is having dysphagia, obviously, patient will have difficulty in breathing and in swallowing. And if they are not swallowing, then they will have weight loss. Okay. Okay. So if you are examining with the mirror, patient is sitting across you, so it will appear like this. This is right side as the patient right side and is the patient left side. Lot of even the resident get confused between right and left. So this is right with the mirror. Okay. This is right and this is left. If you are doing a direct laryngoscopy, then it will be other way around. This will be left and this will be right. So remember, with the mirror, this is right and this is left, as the patient's right and left. All right. And with the fiber optic laryngoscope, if you're looking at it, it's upside down. It is opposite. This is the posterior part. This is the anterior part. Okay. But obviously, this will be again patient's right is right, patient left is left. Okay. I hope I'm not confusing again. This is the patient right. This is the patient left. Okay, so neck examination, you have to see the whether the nodes are there or not. If there's a single node or multiple nodes, and what level the nodes are present. Any questions? Any questions? So what investigation we should do in when you suspect when these patient comes with these symptoms? What are the investigation in your mind which we should do? Anybody? Any guesses? क्या इन्वेस्टिगेशन करेंगे? पेशेंट आ रहा है होस्टनेस के साथ, क्या करेंगे? कोई इन्वेस्टिगेशन जहन में नहीं आ रही? ये तो सबको पता है पेशेंट
imaging or laryngeal.
Imaging. What kind of imaging? बोले आपके पास नहीं आएगा. Imaging of what? पूरा बोले ना. Imaging कौन सी होती है? Explain X-ray कराएंगे या नहीं? Neck का. If you are suspecting tumor of the larynx or hypopharynx, what radiological investigation you would ask for? Come on, बहुत easy question.
सर प्लेन एक्सरे होगा, उसके बाद सीटी करवा सकते हैं.
प्लेन एक्सरे क्यों करवाएंगे? क्या नजर आएगा? अच्छा क्यों कर रहे हैं? Why you want to do a radiological investigation? What is the objective? आपने
सर जो इनकी प्रेजेंटिंग कंप्लेंट्स हैं उसमें अगर डिफिकल्टी ब्रीदिंग है और हमें थोड़ा जल्दी कंक्लूजन पे आना होगा ताकि पेशेंट को भी रिलीफ दे सकें, तो बायोप्सी वुड टेक टाइम, हिस्टोपैथोलॉजी विल टेक टाइम. एक तो ये ऑब्जेक्टिव होगा.
Good. Okay, that is one objective to confirm your diagnosis because you have already examined the patients with these symptoms with your indirect laryngoscopic mirror in the clinic or with the fiber optic laryngoscopic mirror. So you have seen something there, obviously some abnormality. So you will ask. So plain X-ray में क्या नजर आएगा? Plain X-ray में बेटा कुछ नजर नहीं आएगा, except that you will see a shadow of the epiglottis, but you won't see. The reason we are doing the CT scan in laryngeal carcinoma is obviously, as you said, to confirm your diagnosis, to see where the mass is, and it will be visible in the CT scan of larynx. It may not be visible in as clearly X-ray. So remember, do not ask for plain X-ray neck. It's a waste of time and waste of resources. If you have seen a suspected lesion in the larynx or hypopharynx in your examination, or if they're presented with neck nodes, to do a CT scan, okay, because you want to see exactly where the tumor is and which part of the larynx is involved, supraglottic, glottic, or subglottic. And another important thing is for the staging. So if it has got the erosion of the laryngeal cartilage, which are thyroid cartilage, arytenoid cartilage, cricoid cartilage, then it becomes stage 3. And if it has gone through and through the thyroid cartilage and it has gone beyond outside the thyroid cartilage, then it becomes stage 4 or T4. So that is the whole idea. Okay. So right, let's talk about neck nodes because we are examining the neck node as it's a single hair, multiple hair, bilateral hair, or what level. So we talked about the various level of the neck nodes. Level 1 is the submental submandibular region. Level 2 is from skull base to the hyoid bone. This is a quite good picture. Remember, this is up to the hyoid bone. Between hyoid and cricoid is level 3. Below the cricoid is level 4, and level 5 is the posterior triangle behind the sternum-masthead. This is a simplistic picture of defining various neck node level. Most commonly, the laryngeal oral cavity carcinoma, first line of first echelon, we call it, is level 1 or 2. Okay, and maybe level 3, and in time maybe level 4. In laryngeal and hypopharyngeal carcinoma, most of the time level 1 is spared. It is level 2 and 3 and 4. Again, there will be an MCQ whether which levels are involved in the laryngeal carcinoma initially. Okay, so it will be level 2, 3 and 4. These are the first echelon, as they call it. First line of drainage of the lymphatics from the larynx is from the 2, 3 and 4. These are most commonly involved. Okay. So this is just a written material. You can better understand with the pictures, I think. Okay, levels. I did not go into these levels. Paratracheal and mediastinum. Just remember levels. These 5 levels in larynx and hypopharynx. Paratracheal is important in thyroid carcinoma. We'll talk about it if we get the time when I give the lecture on thyroid side. Okay, this is again same picture. Let's go. So this is an investigation. This was the question I sent to you on Edmodo. The investigation, obviously, you will do the general investigation to assess the nutritional status of the patient. Like whether the patient is anemic or not. So obviously, you do a full blood count or complete blood count. Urea creatine electrolyte is important if somebody is having dysphagia. So you want to see if patient is not dehydrated or any electrolyte imbalance like hypokalemia, blood sugar. You would like to assess the status. Chest X-ray. And in laryngeal carcinoma, when we are asking for CT scan of the larynx or neck, we should also ask for the chest, unlike oral cavity, because there is a relatively higher incidence of metastasizing to lungs in the laryngeal and hypopharyngeal carcinoma in comparison to oral cavity or oropharynx tumor, because larynx is a continuation of the airway of the trachea and then the lungs. So if you are suspecting laryngeal carcinoma, so not only CT scan of the larynx but also the chest. The chest X-ray, plain chest X-ray, to assess the patient does not have cardiomegaly or chronic obstructive pulmonary disease. And what are the specific investigation is to stage the tumor. So as I said, CT scan larynx with contrast. This contrast material is ionic or non-ionic, and the tumors are enhanced with contrast. So whenever you are suspecting malignancy in any part of the body, and if you are asking for the CT scan, you ask CT scan is the contrast. The prerequisite for this contrast is the patient should have a good renal function. So we always ask for serum creatinine before we send the patient for this test. If patient has got a poor renal function, then unfortunately we cannot give them control. This is a limitation. Okay, and then we obviously, once we have done the examination in the clinic, we have seen the tumor. Anybody, as I said, who has got a hoarseness for more than 4 weeks, we should examine the larynx. And it doesn't mean that they will have a tumor. As I discussed in last lecture, the commonest cause of hoarseness will be voice abuse. So occupation comes into play, and it could be non-specific laryngitis or vocal cord nodule of polyp in majority of the cases. Carcinoma of the larynx is fortunately relatively rare in our society, and over the last 29 or 30 years in Pakistan, when I came here in 1992, when I returned here. So I was seeing more and more laryngeal carcinoma in those in the 90s and early 20s than oral cavity carcinoma. Now, in the over the last 10-15 years, I am seeing more and more oral cavity carcinoma rather than laryngeal carcinoma. The reason perhaps could be that now, because of the anti-smoking campaign, the smoking is not as commonly seen as it used to be in before 20s, before 2000. So that could be one of the significant reasons of a drop in the laryngeal carcinoma. And the rise in oral cavity carcinoma obviously is this gutka and pan and chalia, especially gutka and chalia. Because of this, we see more and more oral cavity carcinoma. Okay, so we do the direct, in order to stage the tumor and confirm the diagnosis, we do the CT scan and direct endoscopic biopsy. So this is the picture of the CT scan. This is the right side, left side, and you can see this heterodensity mass in the left vocal cord. Thyroid cartilage is intact, so it could be T2. It is not T3 or T4. These are the various pictures of the CT scan. This is the supraglottic. There is a mass in the supraglottic on the right side. Another picture, another picture. Okay. So the reason it is contrast, you can see the IJV and common characters are visible. So when these are highlighted, you know it is a contrast has been given. So if somebody asks you, how do you know this is CT scan with contrast, without contrast? So you look at the big major vessels of the neck. Okay. This is the fibropic picture of the tumor. So this is anterior part, this is posterior part, this is patient right, this is patient left. So you can see the fungating growth on the right vocal cord. So this is how you do a direct laryngoscopy in theater under anesthesia. The objective is